It's now my distinct pleasure to introduce Dr. Emily Jacobs. Emily is a professor of neuroscience at UC Santa Barbara and director of the Ann X. Bowers Women's Brain Health Initiative, where her pioneering research has earned her recognition as one of Science News's top 10 scientists to watch. A former faculty member at Harvard Medical School, she now leads global efforts to advance women's health research through partnerships with the National Academy of Sciences and the Milken Institute, with her work featured in major outlets like New York Times and TED. And she's also just a huge icon and celebrity. It's really, really brilliant, and it's been such a pleasure to work with her on this series. So please join me in welcoming her.
Hello, everybody. I just couldn't be more pleased to realize that here we are at the end of a week, and you could be anywhere and you chose to be here. That already feels like a huge home run. Women's health is understudied and underfunded, and that has been true since Record TV began. We're going to change that narrative. This event is a three-part series. We started 2 months ago, having sort of a historical overview of women's health and where we're at, the progress that we're making. Last month, we heard from the incredible Dr. Magdalena Martinez-Garcia on the status of maternal mental health and all of the great work happening to really shine a spotlight on maternal health. And this week, we're kind of coming full circle across the lifespan, and we're going to hear from truly one of the greatest minds in the space of menopause care. But before I get to those introductions, I wanted to paint a picture of where we're at. You know, when we think about the status of women's health in society, we can go really far back, but even just thinking about sort of modern history, recall it took a literal act of Congress to require the enrollment of women into clinical trials. This was the 1993 NIH Revitalization Act. To this day, most of our preclinical research that's conducted in animal models continues to be done in male animals. So, you know, women's health writ large is really an uphill battle. The first ever White House conference on women's health research happened in 2024. So, and then if we want to put kind of real numbers on this phenomenon, there's just been a chronic underinvestment in menopause science. So if you look back at the most recently indexed fiscal year, 2024, so the National Institutes of Health, this is the world's largest funder of medical research. Right? The U.S. historically has committed more funds than any other country on this planet. So when we looked at the NIH, 2024, menopause research dollars amounted to 1.9% of the NIH's total investments on women's health. And women's health in general, right, with 51% of the population, but actually less than 10% of NIH dollars goes to conditions that primarily affect women. So when menopause is 1.9% of a tiny sliver of the pie, we're talking really small numbers. It's actually 0.1% of the total NIH budget. Just to put that into perspective, 2024, the number of dollars advocated for menopause science, $59 million. The eczema budget was 66. Electronic nicotine delivery systems got $67 million. Back pain, 69, and bipolar disorder was funded at a rate of $89 million. Nobody's going to sit here and make the claim that we should defund or underfund something as important as bipolar disorder. But when you look at a condition that has an estimated prevalence of 2% of the population, and you compare it to something like menopause that will affect half of the global population, you have to ask, how have we underinvested in this phenomenon for as long as we have? What are we going to do to change it so that we have answers to fundamental questions about our body? So with that, you know, the Women's Brain Health Initiative is here to shine a floodlight on women's health throughout the lifespan. You can find more materials, participate in science, because that can really drive discovery forward. We would love to have you. But most importantly, I want to talk about our featured speaker tonight. I had the immense privilege and pleasure of meeting Dr. Patil up in Sacramento. We were advocating for 8432, the Menopause Care Equity Act, with Rebecca Bell-Kane. She can tell you about that. It was a series of roller coasters to try to get this bill passed, even in a state like California. And this bill was going to require continuing medical education requirements for doctors so they know what they're talking about when they walk into clinic, and fund medically necessary FDA-approved menopause care. Took 2 false starts. Newsom vetoed it in 11th hour last cycle, but has come back and kind of made amends for that. And Dr. Patil can tell you more about that. Rajita was hand-selected by the Assembly member to present the case to Congress because she has single-handedly led a transformation in what menopause care looks like for women. She is director of the UCLA Comprehensive Menopause Care Program. This is essentially one-stop shop where you can have providers across disciplines, not just OB/GYN, but really sort of across disciplines who can meet you where you're at. She'll tell you all about that today. But it has become truly a model that needs to be replicated across the country, and she's actually able to secure state funding through the legislature to cookie cutter her model from UCLA to every single UC campus with a medical school. This is huge. It will transform menopause care in our state. Now we need the tidal wave to happen. Rajita is got my training. She trained in medical school at University of Illinois, Chicago, and CSF for her residency, and is now we're so lucky to have her in our state and leading the way for all of us to receive the care that we deserve because of incredible people like her. So without further ado,
Thank you.
Thank you.
Thank you so much. I'm so excited to be here to connect with you all, and I hope that you leave here with some really good information, some evidence-based information. And so I'm going to just walk you through a little bit of what we're going to talk about today. So we're going to walk through how menopause represents both a window of vulnerability, but also a window of opportunity. And we're going to review whole person menopause care. We're going to examine the current access gap that we have here today in the US, and we're going to highlight the UCLA menopause program and kind of look at it where we're going as a UC path forward, as a UC-wide initiative, and as a whole California solution. So we're going to start with a case because I think most of you will relate in some ways to this person. This is a real person, okay? So this was a 42-year-old South Asian woman that came to me in my office. She has irregular periods. She's young. She's had symptoms for about 18 months and they've gotten worse. She's not feeling like herself. She feels hot flushes during the day and the night. She's feeling really tired. She has disturbed sleep. She has heightened anxiety and irritability. She's feeling like she's gaining about 5 pounds without even thinking about it. She's not interested in having sex anymore. And her symptoms are worse around her period, but she really doesn't feel good, just even in general, beyond that. And it's really affecting her quality of life at home and at work. She feels disconnected, less motivated, really frustrated. Her history is also notable for her last blood draw, showing that she has some new onset prediabetes and she has a worsening of her cholesterol. Her new job she just took on, she's really having a hard time concentrating, and she's just one of very few women in the office. She lost her home in the LA fires. She has 3 children. She works out occasionally. She doesn't really have time. She doesn't have time to cook, but she tries to be a pescatarian. And she doesn't have any time to really just ground herself in everyday, regular stress reduction practices. I know this is a lot of details, but do any of you feel like you can relate to this person? Yeah? Okay, or know someone that might relate to this person, right? And so I bring up all these details because these details are actually really important, and I'm gonna show you why. So let's start with the lived reality of a midlife woman like Nina. The average age of menopause in the US is 51.4. With women now living into their 80s, many will live 40% of their life in postmenopause. And menopause arrives at the most busy time, the most demanding time in life. This is the superwoman stage, right? lots of caregiving happening. Could be children, could be elderly now, could be empty nesting, actually. That's also a stress and something that you have to kind of cope with. There might be intense career demands and financial pressures. And there's really not a lot of time for self-care. And then menopause hits during this busiest, demanding time. And this is a sudden, not a gradual, neuroendocrine shift that really disrupts the equilibrium, disrupts the sleep, the mood, the cognition, the energy, and that really destabilizes an already stretched system. So what's really striking and alarming is that over 50% of women in menopause will have menopause symptoms, and they never receive care. And fewer than 5% will ever receive menopause hormone therapy, even when they're eligible candidates. And it's even worse for marginalized populations. Now, when imagine that you're going through this decade, right, this demanding decade, and you're having fragmented sleep, cognitive changes, fatigue, mood shifts. Well, what once felt manageable really becomes unsustainable. And that's where superwoman phenomenon turns into superwoman syndrome. And it really leads to a huge impact on quality of life measures, which includes just the way you live your life on a day-to-day. There's a lot more ability to have stress at home, and it impacts your work. Now, there's not one single menopause experience. There's over 60 documented symptoms which extend across multiple organ systems. There are hundreds of receptors for estrogen everywhere. About 80% of women are symptomatic, and for many, vasomotor symptoms last 7+ years, with 10% having symptoms into their 70s. And what matters more than prevalence is actually variability. So no two women of the same age in the same stage of this transition will have the same experience. So their cluster symptoms, their severity, their timing, their duration, it's unique for every single person. And that's why this one-size-fits-all approach, it really fails for menopause care. Now, these symptoms, they don't occur in isolation. They interact like a web. Hormonal fluctuations drive these hot flushes, vasomotor symptoms, sleep disruption, mood instability, and cognition changes. And they all affect each other. So hot flashes, they worsen sleep and mood. Poor sleep worsens mood. Poor mood worsens sleep. And all of this affects cognition and fatigue. So when a woman says, I don't feel like myself, she's really describing a cumulative system strain and not one single symptom. And that's why treating symptoms in isolation often fails. Now, mood is one of the most destabilizing domains of this transition. Several forces really converge here. Rapid estrogen and hormonal shifts, like with progesterone, they disrupt the neurotransmitters that regulate mood. And sleep fragmentation erodes emotional resilience. And these midlife psychosocial stressors and demands that we just spoke about, they amplify that emotional strain too. And then cognition fog or disruption really undermines confidence, and especially for women at their career peak who have lots of responsibilities. And then body and metabolic changes, they affect identity, self-esteem, and relationships. Together, these 4 pathways, they really amplify vulnerability to mood disruption. And that's why women who have never struggled before with mood suddenly feel anxious, have irritability, labile moods, and feel overwhelmed and even depressed. And those with a history are at a much higher risk for recurrence and relapse. Now, hot flashes are one of the most common symptoms of this transition, and they are far more than just a nuisance. Hot flashes are a systemic signal. They are associated with systemic inflammation and blood vessel injury, and they are correlated directly with increased cardiovascular risk and disease. As I showed you before, they also correlate with sleep and mood disruption, and these 2 things also independently affect and directly correlate with increased cardiac disease. So in effect, unaddressed menopause symptom burden is actually linked to more cardiovascular disease. And what affects the heart affects the brain, and it affects every single organ in the body, increasing risk for dementia and osteoporosis and many others. So treating menopause symptoms is not about comfort alone. It's actually critical. It's a prevention. It's critical that we focus on prevention, and it's a window of opportunity for long-term health. Now, cardiometabolic risk factors also accelerate during menopause due to the loss of estrogen, and this leads to more future heart disease, as I mentioned. So we see rapidly increasing blood pressures, we see cholesterol worsening, we see fat accumulating around organs and more insulin resistance, and actually a loss in lean muscle mass. So all of these things result in this weight gain and metabolic syndrome. And these changes really cluster during this transition and shape these long-term outcomes and risk for heart disease and clinical events in the future, like a heart attack or a stroke. So the menopause transition is a window of vulnerability, but at the same time, it's one of the most powerful windows of opportunity we have to really focus on how to prevent or early intervene to really shape that long-term trajectory of health. And this is where this vulnerability and opportunity really intersect. Lifestyle factors, as illustrated by this wheel, this American Heart Association's Life's Essential 8 wheel. So getting good sleep, abiding by a diet full of whole plant-based foods and less processed foods, getting 150 minutes of moderate intensity activity. What does that mean? Well, that means like not being able to comfortably have a conversation while you're exercising. Having good sugar and diabetes control, weight control, cholesterol, blood pressure, not smoking, right? All of these things. But I had to add to that 3 more things. And actually, I think 4 things. Daily stress reduction practices, social connectivity, having a community, having your support, and having regular mind-body spiritual alignment. Landmark data from the Nurses' Health Study, shown in the upper right graph, shows that an adherence to this lifestyle pattern was associated with an 82% reduction in coronary events. And later analysis that you can see on the bottom right demonstrated that the more of these factors that you abide by, the more life you have to live by up to 14 years. That's a lot. So it's a lot about how we live our life, right? This is the most powerful tool that we have. This is really the magic recipe to healthy aging. But we are going to talk about other organ systems as well. So we need to talk about the brain. And I know how many of you have experienced or hear about brain fog, right? So it is a very prevalent symptom of menopause, okay? It happens during this transition, and 60% of people experience this. I actually think it's more, but this is what the literature gives us. It occurs during the menopause transition, and it's usually temporary, and there is a loss of neural connectivity in regions of the brain that cause executive functioning disruption, causing attention issues, slower processing speeds, difficulty with word recall, short-term memory. But the brain is a beautiful thing. It is capable of neurogeneration, and time can create new neural connections to compensate for this. This is not equal to dementia. Dementia, 11% prevalence. So all those 60%, they didn't all go get dementia, okay? This is a gradual progression over decades. And there are some non-modifiable risk factors. So I am still gonna agree that the loss of estrogen, we know that's a risk factor. That does affect the brain. That's one non-modifiable thing that's going to happen. Genetics is another. So if you have a family history of early dementia, or you have genes that are increasing your risk, or early menopause, that's also a risk. But we have 14 identifiable, modifiable risk factors that account for over 50% of dementia risk. And I will say, I have this little cartoon here because, again, what's good for the heart is good for the brain. And so focusing on really reducing those risk factors, really focusing on social connectivity, treating the menopause symptoms. We can't control where we live in the air pollution, but especially I'm in LA, it's really, really bad. But we definitely can make sure that we're treating hearing loss and vision loss, and education is another risk factor. But there's many, many that are under our control. The big thing here is that we cannot say with the data that we have right now that hormone therapy is recommended to prevent dementia or to treat brain fog alone, okay? Now, when we move on to the musculoskeletal system and healthy aging, we know that during this transition, this big red area that I've circled, bone density can drop by 12%. That's 1 T-score on a DEXA scan by the time you're 5 years into menopause. But 90% of whether someone's going to get osteoporosis is actually genetic. Not everybody is going to get osteoporosis. We do know that you also lose lean muscle. And so there's a slower resting metabolism. And so that's why people gain weight without thinking about it. And lifestyle really matters. So intaking that calcium, ideally mostly through your diet, getting your vitamin D. You don't need super loads of vitamin D. We're just talking about 800 to 1,000 international units. And having a high protein diet, not more than 30 grams in a meal, because you cannot absorb that. I know people are taking like 50, 60 grams. It's really doing nothing for you, okay? Especially for women, I should say. Men are different. And then engaging in regular weight-bearing activity and strength and balance training to really prevent falls. That's what we're ultimately caring about. And considering that baseline bone scan during this transition, especially if you have family history. Honestly, we do this for every single person going through the transition, and I cannot tell you how much osteoporosis we have found. Now, what about hormone therapy for this? Well, hormone therapy is FDA approved to prevent bone loss in high-risk people, so people with osteopenia who have a very strong family history, but it is not recommended as first-line therapy for osteoporosis. There are much, much, much better drugs out there for you to get the best treatment for that. So while we've been talking about what's happening in the body, the full menopause experience extends far beyond biology. Menopause must be viewed as a multidimensional transition. It is shaped by this biology, but also psychology, psychosocial, right? Things that are going on with you, cultural narratives, and what's personally meaningful to you. All care must address these areas and not just symptoms alone. And because these factors, these other factors, these contextualizing factors, they really are affecting how those symptoms are experienced and how care is accessed and whether you're going to adhere to the treatment plans laid out. So we talked about the psychosocial already. We talked about the biology, but I want to talk a little bit about these other two boxes here. So from a spiritual perspective, menopause actually represents a meaningful inflection point, a time for reflection, renewal, and deeper engagement with one's life experience. It often marks a transition into a new life point, creating space for redefinition, realignment, and new direction. While symptoms might be challenging, many women actually do come to view this in a positive light. And not because the difficulties disappear, but because of what the transition can unlock. Menopause can serve as a catalyst for this growth and meaning making, fostering resilience, clarity, and a more grounded sense of self, rather than the cyclic thing that we're going through before that. In many cultures, it's actually recognized not as a decline, but as a transition towards wisdom and autonomy, and they're actually at an elevated status in society. When framed as a period of growth and expansion rather than loss, menopause becomes a powerful window for transformation and shaping how it's experienced and lived. But the problem is that from a sociocultural perspective, as it is in the United States right now, this is not the case, right? So in the United States, cultural emphasis is on the youth and reproductive identity, often leading to menopause being framed as a decline rather than a normal life transition. And this can really affect how a person interprets their symptoms, whether they're going to go even get care, and how they're going to feel supported during the stage. And then these cultural forces are actually compounded by the structural gaps of our care that Dr. Jacobs, talked about before I came on. So menopause remains underfunded and underrepresented in research, and there's a huge knowledge gap, leaving many patients without access to knowledgeable, evidence-based guidance. And so as a result, women navigate menopause within a system that is both culturally and medically unprepared to support them. Well, this gap highlights a fundamental issue. Our current approach doesn't really capture this complexity. So it's really important to think about care as whole person care. And I think of this in three buckets. I know there's a lot on this slide, but I just want to break it into these three buckets. One is symptom management. So we do want to address that symptom burden across all these body systems. And for perimenopause specifically, we want to think about menstrual irregularity. We want to think about contraception needs because people can still get pregnant in perimenopause. I see it all the time. I'm a complex family planning specialist, so I see it. And we want to identify the red flags for hormone therapy. Not everybody can use that. And we want to use our full toolkit of therapeutic options. It's not just about estrogen therapy. And we have a lot of non-hormonal options and non-pharmacologic options that sometimes synergize together or even alone and work wonderfully. Now, bucket number two is really assessing those other medical conditions happening already, like the prediabetes or the elevated cholesterol. and looking for windows of opportunity for early intervention and prevention to prevent that future chronic disease so you can live your best life. And bucket number 3 is contextualizing and individualizing that care to really get at the root of how we're going to change behaviors and improve symptoms. So back to Mina. Sorry about this black box there. I don't know how to get rid of it. There we go. Okay, so coming back to Mina, this is this multi-dimensional transition in whole person care. You can see vulnerability and opportunity. So you can see that she's experiencing high menopause symptom burden. She has significant psychosocial stressors, right? She has a busy life at home and work. She has a few life events that have caused a lot of stress, like losing her home. She has emerging cardiovascular risk factors. She has worsening cholesterol, prediabetes. She's South Asian. That's a risk factor for heart disease. She's got some weight gain going on. She's not exercising. I don't know what she's eating exactly. And she's got some strong inside internal messaging that's negative. She's been dismissed by her primary care provider, and she has a lot of identity disruption, and she feels alone and unsupported. So the opportunity, again, is multidimensional. We want to validate her symptoms. We want to explain this menopause transition that she's going through. We want to address her symptoms, treat them. We want to talk about prioritizing herself and discuss the importance of doing that in this transition as you know, the protective natural estrogen is not really there the way that it was before. And so it's really not giving her that buffer that she had before this transition happened. We want to address her lifestyle, her diet, her sedentary lifestyle, and psychosocial stressors, and really talk about stress reduction practices. We want to find out who's supporting her through this process and how she can get some help, and consider group care models so that she can find support and community through this transition. This is also a busy slide, and we're not going through all of this. I just want you to know that there's a huge toolbox of options that we have. The left side is all the hormonal options, some of which are contraceptive strength and some of which are menopause hormone therapy and not contraception. But this entire right side shows you that there's non-hormonal options, and there's some really good ones that have come out in the last few years. And then we have non-pharmacologic options, right? So things like cognitive behavioral therapy, this is structured psychotherapy that can really, really help for mood and sleep and vasomotor symptoms, and mind-body practices, and the things we've sort of mentioned already. And so it's not about choosing one option, right? It's about presenting the right options and talking with the person in front of my patient and figuring out what makes sense for her to actually ultimately decide between these guided options. So it's my job to understand her health factors, to understand her symptom burden, to understand her red flags, right? But then I should be presenting her with options, and she gets to choose what's right for her. I do want to dive into a little bit of some of these treatments. So for vasomotor symptoms, we know that hormones work, okay? They're FDA approved for this purpose. They are the first line treatment for vasomotor symptoms if there's no contraindications or cautions. And it's overall low risk for most people, with under 1 in 1,000 risk for blood clots, breast cancer, and heart disease. But not everybody can use hormone therapy. Not everybody wants to use hormone therapy. And we have amazing non-hormonal options now. So Veoza, these are the brand names I'm going to mention. Veoza and Linquite have come out. These work directly at the thermoregulatory zone, just like estrogen does, to really stop hot flashes, and they work. And so we're so lucky to live in a time right now that we can offer these options. And I hope more drugs come out like this. There's antidepressants and anti-anxiety agents that work. Gabapentin works great, and cognitive behavioral therapy is so powerful. And you don't need to use a drug. Now, there's very limited data on lifestyle, mind-body practices, acupuncture, and supplements in terms of actually improving vasomotor symptoms. But I am just going to say that in every study we look at, there's a huge placebo effect. I could give you a sugar pill and say it's a drug, and we will see a 40% reduction in hot flashes. It's crazy. So we always have to compare to placebo. So all those supplements people are taking, a lot of them have been studied, and I'm not discounting all of them. I'm just saying to you, they're also just wanting your money. And so just be careful. And we want to really work with data, and we have to do a lot of work in the supplement space. We don't know a lot. Now, when we look at sleep, I'm actually going to put both of these next to each other. So sleep and mood, they actually kind of mimic each other very, very well. If you see that, we know that they're an interconnected web, right? So if we treat hot flashes, we're going to get better sleep, we're going to get better mood. If we treat mood, we're going to get better sleep. If we treat mood, we're going to get better sleep. And stress reduction practices help both, right? And then we want to focus on sleep hygiene. That is really, really key. So just really building that in during this transition really helps. And focusing on social connectivity, and then lifestyle modification, right? So diet, exercise, avoiding alcohol, excess water at night. And then cognitive behavioral therapy works for both of these. We want to rule out sleep disorders. We know sleep disorders rise during this time, like sleep apnea. So when we have persistent symptoms, we really do need to get that sleep study. And then for mood specifically, when we have clinical depression or anxiety or any other mood disorder, we don't use hormone therapy for that. There is some role for hormone therapy. There has been some data to suggest that estrogen can help with sort of that new exacerbation or that new onset, but it's not FDA approved for that purpose. And I will just say persistent issues really do need other psychotropic medications with a psychiatrist or a primary doctor. So what are the indications for hormone therapy? So the number one reason, and we talk about menopause hormone therapy, right, is to treat menopause symptoms in low-risk patients. So it's FDA approved for vasomotor symptoms only, but it's off-label use for all these other symptoms. Now, the second reason to use hormone therapy I mentioned before is to prevent osteoporosis in high-risk individuals. HRT, which I know people say everything's HRT, but that's actually not true. HRT, hormone replacement, is actually to replace hormones like an endocrine disorder, like thyroid. That's for people that are going through premature menopause under the age of 40. We do not use hormone therapy to prevent heart disease or dementia. So this is also a list, and I'm not going to go through all this, okay? But I just want you to know that if you lie, if you find yourself in one of these, it's not a hell no, okay? But it's also not a hell yes if you don't meet any of these criteria. It really is so important that you have a nuanced discussion with your doctor about what is going on with you, what is your symptom burden, what are your health factors, your red flags, and then really make an educated decision around what makes sense for you. Now, I want to just briefly go over some menopause hormone therapy terminology, okay? So we talked a little bit about HRT versus MHT. So hormone replacement versus menopause hormone therapy. HRT is for those that are getting it under 40. We're giving higher dosages. We're actually replacing. MHT is more, think of it like a supplement of estrogen. Your ovary is still going to work and be active. It's not replacing anything. It's just giving a little bit of a boost back. And that's really for menopause symptoms over the age of 40. And some might argue 45 and as these numbers instead of 40. Now, what's the difference between bioidentical and synthetic, right? Everybody's like, I just have to be on bioidentical. Well, everything is derived from a plant. I just want to be clear about that. Nothing is coming from a human, okay? And nothing can replace the way your body creates that estrogen. It's not the same thing. Even though bioidentical means it's identical to the type that's created from the human ovary, it does not mimic it. It doesn't fix everything. Now, synthetic is also safe, and we oftentimes have to use it. It's not exactly identical to human estrogen. Now, what's the difference between FDA approved versus compounded? FDA approved means that we actually know what's going on, what are they putting in there? It's being regulated by the FDA. So we know the purity, the potency, the efficacy, and guess what? It's actually covered by insurance mostly. Compounded is a marketing gimmick out there. Okay, there's no oversight or safety concerns, especially the pellets are so dangerous. We could do a whole lecture on pellets. But the concern around this is that we don't know what they're putting in there. There is a concern of overdosing and underdosing, and you can have an unregulated release of hormone with the pellets, and we don't know the base compound they're mixing it with. The uterus, oftentimes with progesterone, we have concerns because we can't guarantee uterine protection when you're using compounded progesterone, and it's very expensive and it's not covered by insurance. And the biggest takeaway here is that FDA-approved bioidentical hormones exist and really should be first line. Now I have to mention the black box, okay? So the black box came off late last year and everybody was, hooray, everything is safe, there's no risk. That is not true. Okay, so it didn't belong there, but for systemic estrogen, so in menopause hormone therapy for menopause symptoms, The black box removal is better aligned with the idea that this is low risk and it doesn't deserve to have a huge warning on there, but it doesn't mean no risk, and it still requires that risk-benefit assessment. With vaginal estrogen, it's totally different. I have no idea why they even could even put this on there. There's minimal to no absorption of vaginal estrogen into the bloodstream. This is the type of estrogen we use when people have genitourinary symptoms of menopause. And so there's absolutely no reason for this label to have ever made it on there. I want to talk a little bit about this idea of, I love this idea, menopause empowerment, okay? Menopause empowerment emerges when individuals are supported with both internal understanding of what's going on with them, but they're supported externally and they're given resources. Women feel empowered when they have access to clear evidence-based information. They work with clinicians who listen and offer them options and are supported by environments, healthcare systems, workplaces, communities that reduce stigma and enable care. So this is not conceptual. This is not just conceptual, I should say. Like, we know in literature out there, when people feel empowered, they do better. They have better outcomes, healthcare, short-term and long-term, and they adhere to the plans better, and they feel a greater sense of agency. So ultimately, empowerment comes from creating a care approach that really looks at the whole person, like I've been mentioning. But the problem is that we are facing a true bottleneck in menopause care across the United States. Awareness and demand have risen sharply, but the supply of trained clinicians has not kept up pace due to the gaps in education and institutional prioritization. And the result is long wait times, limited access, and a system that cannot absorb this demand. And this has really led to an erosion of trust in the medical system. When patients can't access care, they turn elsewhere, right? To social media, to influencers, to supplement companies, to direct-to-consumer platforms. Much of that information is not evidence-based and can actually at times be unsafe. So by the time they reach me, I'm often spending a lot of time correcting this misinformation and misguidance. But here's also the clinical reality. Even if a person is motivated and knows a lot about menopause, they face a really hard reality in the office as a clinician. In 15 to 30 minutes, they're expected to do a lot of things. They have to manage this complex multi-system, condition, provide the nuanced risk assessment, engage in shared decision-making, and at the same time, a lot of the counseling is pretty repetitive. And there's a huge administrative burden after the patient leaves the room, and that's not reimbursed, by the way. And menopause care is not procedural, right? So as OBGYNs, I'm gonna be honest, we make our money by delivering babies and putting in IUDs. So it's financially not incentivized by the medical system. And time in the room spent to correct misinformation takes away from time that we need to actually give good information. The cognitive load is enormous, and that's why clinicians don't want to care, and they don't want to deal with menopause. But this tells us something important, right? That education alone is not going to cut it. We need to have tools and system solutions that are going to help us be successful at delivering care in 30 minutes. So how do we do this? I have 3 solutions that have sort of worked for our system, okay? And I'm going to go through our system after I present these solutions. Number 1, education percolation. So how do we do this? Well, education is still really important. The idea of embedding, what do I mean by education percolation? I mean embedding menopause training directly into the workday so that knowledge spreads and diffuses across the entire medical system. We cannot rely on a small number of menopause specialists to meet the full demand for care. I could have 50 menopause providers in my program. It will not suffice. Okay, our wait times are over a year, and I just tripled our number of people that are serving and trying to provide care. Wait times haven't changed. We cannot. We really need to have most of menopause care actually is low risk, and it's manageable by generalists, by the frontline worker, the primary care providers, and the other OBGYNs. But they have to have the right foundation, which is currently missing. So we need to address this by embedding it within the workday to make it easier for them. And then we work through through diffusion. Like if I got one champion over there that knows what they're talking about, that's going to diffuse through the office. And that's how we get people trained up. And we also have to really focus on the pipeline, the future pipeline. This takes a little longer, but we really do need to be focusing on giving them really good information so that they're set up for success when they go out there and practice from the get-go. Solution number 2 is structure support. So we need structural support to deliver this care efficiently. We need multi-collaboratory collaboration with like our specialists that we want to work with clear referral pathways for people. We need standardized workflows to reduce that variation and reduce the cognitive load and to really just improve equity of care across populations. And we need to embed decision support tools for clinicians so that we can give you faster, safer solutions that are still comprehensive and personalized. And we need flexible care pathways. So things like telemedicine and group care can actually work really well for the patient, but also for the provider. So that instead of me saying to 10 different people in 10 different visits the same thing, I'm addressing this in a community feel, and I'm doing a lot less talking actually, and they're all learning from each other, and we're getting all of this and more across than we would have if we had individual visits. Solution number 3. So this is where care models and pathways become essential. So as I said, the foundation is generalist care because most menopause care is low risk and can be managed by these primary care providers and OBGYNs. In parallel, we have these direct-to-consumer models, right, that exist, and so they're essential. They are helping to fill a void, but neither approach is sufficient for complex multidimensional care. We need a comprehensive hub-and-spoke model where the central hub is these menopause-trained specialists like myself, supported by a multidisciplinary team to manage this complexity, but then a network of the frontline clinicians who act as spokes to kind of manage the patients on the front line. And we need these flexible care pathways for patients and providers. We want in-person options, telemedicine options, one-on-one group. We want hybrid options. We want asynchronous care, right? Care when you leave the office, you have something to look at, you have something to hold yourself accountable for. All right, so this brings us to UCLA. So this is what it looks like in practice, all right? So at UCLA, we built this system that actually has these 3 things in there. And our mission was very simple. We want to deliver evidence-based, individualized whole person care. And we have a bunch of goals here. We want to improve clinical care. We want advanced training and education. We want to address research gaps. And we want to really advocate for policy change. And I will just add a 5th one is really innovate and think about how to change these health systems. So at UCLA, we developed something called the MAPS. It's the Menopause Assessment Pathway Support System. It's a whole person clinical framework built with input from our specialists. So what MAPS does, and just follow me through here, it integrates a pre-visit online patient questionnaire with the electronic health data that you already have in the system, and it applies organ and symptom-specific algorithms that were built by our team together using evidence-based guidelines and our specialty expertise. And we generate a red, yellow, green risk stratified snapshot before the visit even starts for each symptom and organ system. This allows the clinician to walk into the room already having the snapshot and understanding what your symptom clusters are, what your risk factors, what your health, what your genetics, what your lifestyle approach, and what are you valuing, because we have questions about this. And this visit, then when I see you in the room, the visit shifts from data gathering to much more about contextualizing and interpreting together and coming up with the guided recommendations that we need and to discuss and coming up with a care plan that makes much more sense for you. So for the provider, it reduces our cognitive load, standardizes care, and improves efficiency. But for the patient, they get a one-stop solution where they get the personalized care plan in 30 minutes. Now, one of the most powerful features of the UCLA CMP is that it was intentionally designed as a multidisciplinary whole person model. So our team is huge. We have 14 core menopause providers that offer complex and low complexity care. We collaborate with 30 specialists across UCLA, and you can see them all here. We have trainees that we're training, and they're part of our team. We have allied health professionals, and we have a whole clinical operations staff devoted to us. This breadth really matters because menopause touches every single organ system. Now, I want to bring up a model that really is dear to me is centering menopause. I don't know how many of you know about centering pregnancy or have ever heard of centering pregnancy. Anybody? Okay, so it's a group-based care model, and it integrates clinical care, education, integrative medicine, and community all in one. It's adapted from centering pregnancy, and it treats menopause as a shared developmental transition. So what happens here is that First, everybody in the group does a self-health assessment of themselves to create patient agency. And then there's interactive learning through facilitated group activities and discussion, and then community building. And each program is about a cohort of 8 to 12 patients. They go through 10 sessions listed here, co-led by clinicians and specialists, and they move together rather than alone. So here's an example of a sleep session, right? It always has objectives, but we start with community building. So we reduce isolation by doing like an opener, okay? Then we follow that with interactive learning. So for example, in the sleep session, participants mapped out their sleep burden over time. We made like a line in the room and everybody just stood where they felt like they were that day, like how their sleep was on a 0 to 10 continuum. Then we asked them, well, what about a year ago? What about 5 years ago? It really helps to kind of give some understanding of what's going on with them for that symptom. We also explored contributors using interactive exercise and adult learning theory, as well as identifying relevant barriers to sleep in their own lives using facilitated discussion. And then sessions end with a mind-body practice and brief one-on-one consults with the specialist. At this point, they've received a lot of counseling and information, so those brief consults are actually pretty brief because they know what things are going on with them and they can really hone in on that for that brief visit to kind of figure out what's the next step. And then we give them tools for tracking symptoms and goals between their visit. They also receive curated resources for between their visits. So it really transforms menopause into something where they're not feeling alone, and they can really navigate it with knowledge, connection, and support. So this is some of our pilot data. It's really interesting. I know there's a lot of colors here, but if you can just look on the left, there's basically all these 10 sessions, okay? The top half of the screen is pre-session, the bottom half is post-session. And so what we see is that across all 10 sessions, women move from low confidence in the purple to high confidence and feeling confident about their topic in the green. And the same thing happened when we looked at how did it boost your knowledge for these topics before and after. So definitely they noticed an improvement. When we looked at, that was quantitative data, but then when we look at the qualitative, just like what do they feel, what do they think, we did some interviews. And so this is just 2 quotes that I pulled out from patients in the cohorts. In individual care, you sometimes have 5 minutes, sometimes 20, and there's always someone knocking at the door or something. It's very quick, but here you've got all the answers. There's so many general questions that I wouldn't have time to ask in an individual setting. Another patient said, you don't get access to a provider like that for 2 hours on that level, with that information, with all these questions, with this format and prompts that are ready for you. It's so invaluable. So these are the things that make me really happy and excited about trying something new. Now, when we looked at actual outcome data, when we said, okay, look, we have this whole process, right? Like, well, what happened to their symptoms when we looked at when we used the maps? And so what we saw is that we looked at hot flashes, we looked at depression, anxiety, stress, insomnia or sleep issues, cognitive issues, urinary distress. All of these numbers significantly improved between the baseline before they saw us to the follow-up time. So they always fill it out before we see them. And so we can see here that when menopause is treated as an interconnected system, it's much more effective. And when you treat one thing, you're improving another. Now, this slide just shows what happens when we embed menopause education directly into the clinical workflow, that education percolation and how it really translates into more capacity to provide care. So in year 1, we grew from 3 to 7 providers and across 3 UCLA sites. We also embedded a didactics curriculum for residency and medical school. And in year 2, we expanded by 8 new OBGYNs and 2 additional sites. We now started having residents rotate with us, get hands-on experience. And we started providing continuing medical education in a very formal way locally for our providers. And then in January of 2027, we are planning to expand by 10 more primary care providers and 3 more OBGYNs and more sites. And we're hoping that in spring of next year, we're gonna be the first to launch a menopause fellowship. So that will be very, very exciting. And we're almost at the end here, so I just wanted to mention a few more things. This is really a great slide to me because it really shows how menopause patient volume across the UC sites, what happened when we had this structured program. So after launching CMP in 2023, UCLA as a whole system, when you looked at the menopause visits shown in green, you can see that there was an increase by 55% in 2 years compared to 19% in the years before we started the CMP. Compare this with the other 5 UCs, all the lines on the bottom, that don't have structured programs yet. They showed minimal growth. And so now UCLA delivers over half of all the menopause visits in the UC system. And this really shows that when you have structure, it really turns that demand into having access. So 1 year ago, the UC system came together and we formed the UC Menopause Consortium Collaborative. And this was under a shared recognition that menopause care is both a clinical priority and a health equity issue, and that no single campus can solve this alone, and we need outreach into a lot of different rural areas. What you're seeing here is the foundation of our goal, the UC Center of Excellence for Menopause and Midlife, with UCLA serving as the coordinating hub. This structure will allow us to align our governance, clinical care, education, research, and community engagement across the campuses, while still working within the context of each UC's environment. And importantly, this is not just a theoretical model. We have received some initial seed funding from the state to begin this work, along with centralized infrastructure support led by the UCLA CMP. 5 additional UCs will start to adopt this framework in the next year, with the hopes to expand menopause care across the state. But to make this sustainable for this UC-wide initiative and to meet the population demand and to support, we really do need support from individuals, from community, from organizations and systems to really make this happen. A key next step for us is a hope to develop a UC-wide menopause registry for research so that we can leverage all of the standardized workflows and data that we get to really answer important research questions in the past as well as going forward. So the vision for me as the director of the UCLA CMP is to really transform menopause care from a fragmented and inaccessible system to a coordinated and evidence-based and scalable system, and position UC as the national leader in how midlife care should be delivered, studied, taught, and to provide care to as many Californians as possible. And so with that, I thank you so much for your time, and I look forward to some Q&A.
So we have time for a few questions.
Hi there.
Hi.
Thank you so much. I do love the evidence-based science, this path with opinions, and it's a scientific approach and also the solution. Let me challenge you for a moment on this study on slide 38. You have the results. So are you saying that a bunch of women participate in this 10 knowledge sharing session, and essentially they have less hot flashes? So essentially the education improve the system? Was it not that the symptoms? Was it not that they aged out a bit, for example?
I see. So the slide I showed you, I probably should have mentioned this, the one that has like the box with the significance, that one, between the pre and the post, that wasn't just centering. That was actually 2,000 plus patients. And that was because of the way we managed that with pharmacologic options and non-pharmacologic. So it's not just centering. Sorry, the centering data ended up before that. So no, we absolutely we need to be synergizing with pharma, with drugs. But yeah, this just shows you, that slide was meant to really show you that you can actually achieve improvements in all these symptoms at one go.
Hi, thank you very much. I'm in part of the UCLA medical system, and you're touching on that. I often get these requests for my samples, and I haven't. Do you know what I'm speaking of? So there's a system part of UCLA that want me to give more blood for research that's happening. So I was wondering, is there any research that you're currently doing, something like that?
There's so the first few years, we've been live since August of 2023, and I would say the first few years we've just been focused on sort of the clinical build and the education. And now we've sort of set up the research frameworks, and there are actually lots of little projects starting to happen in different, because all of these these specialists, whether it's GI or it's bone, endocrine, or women's cardiology, they're part of our team. And so they're all wanting to start to now do research. And so we have a lot of small projects that are starting to happen where we are, it's more of like a prospective study where we are going to be getting some of that like the blood samples and things like that. But we don't have anything really, really big yet. But that's coming. One of the things we ask in every questionnaire when someone fills it out is if they're willing to engage in future research. That helps us.
I'm wondering if you could provide some suggestions as to how we can successfully navigate conversations around menopause care with our providers. Because a lot of the symptoms that come up for people during menopause, I imagine it's hard to pinpoint precisely what's influencing that. Like, is menopause the cause, or is something else the cause? And I'll use myself as an example. In my annual visit last year, I brought up to my doctor that I was tired all the time, and that's unusual for me. And that has been going on for months. And so she asked me some standard questions when she got to, how often are you exercising? I said, well, hardly at all, because I'm so tired. And her response to me was, well, you need to start exercising again. And I definitely agree with that, but I honestly haven't been able to get back into it as hard as I try. And so even I questioned myself, like, do I just need to get over it, push myself, and test myself as a subject? Or do I need to push more in that conversation to say, I think something else is done?
Yeah, you're not alone. A lot of people, when we use this term, not feeling like myself, it's a real term. It's actually a studied term. And I think that it takes a lot of the art of this is taking the proper history. And I will say from your standpoint, the best thing you can do is start journaling and diary what is going on with you. When did it start? How does it relate to your cycles? If you're having cycles, is it gradual? Is it sudden? Right? These things are clues. So if it's something that's been gradual, that's getting worse, and even if you're having regular periods, you still make this is a whole other talk I give, but it's the late reproductive stage, which is before menopause transition, before you're considered perimenopausal. That's a real stage with real symptoms. Like lots of people have these symptoms where they have fatigue, or they have, they're having mood lability. There's a lot of even hot flashes can happen during that time. And a lot of doctors are not treating during that time because they're like, well, you're not perimenopausal. And that's people don't know, but I think we have to expand our idea of when menopause symptoms are starting and when they can start, and thinking about treating earlier. So I don't know the answer for you. I'd have to ask you so many questions, but I think that it's important for you to advocate for yourself and to also start to keep a diary of symptoms, like what is happening, also what's been going on in your life. Is this sudden? Is it gradual? Like those are important clues. And also, are you sleeping? Like if you're not sleeping well, you're not going to have good energy. So yeah.
I will.
Oh, hi.
So I just want to jump on that because interesting. So when you're not seeing the PMS symptoms, and we're in that sleep, I think as a primary care provider, it's hard to know, would you like to try, a low dose option? Because they can affect the options. A lot of them are still.
Yeah. So yes, and this is also very true. I will say that I actually have a lot of people on birth control, and they're starting to have symptoms. And I think it's because the birth control pill is a totally different type of estrogen. It's not the bioidentical estradiol, right, that your body creates. And so when I switch them to menopause hormone therapy, knowing that it's not contraceptive, or I'm mixing it with a contraceptive to help them keep their address their contraceptive needs, they actually do much, much better. So I think that it is really important to offer, this is off label. I'm going to just put it out there. All of this is off label. There's almost nothing on label. And so I don't think it's harmful if the person is a good candidate to offer menopause hormone therapy as an option to see if it helps them in 3 months. If in 3 months it did nothing to them, like they've done an experiment, they've done a trial for themselves. And so I do that a lot. I know that's not evident, there's no evidence for any of this stuff, but we're in an evidence-free, data-free zone here. So none of the trials really included perimenopause. Forget about late reproductive stage. They didn't even include perimenopause. So we have a long, long ways to go. So for that patient, I would say if she doesn't really want to be on birth control, if she's okay with the fact that menopause hormone therapy is not a contraceptive, you could still try and menopause hormone therapy, or you could do a mix of estradiol with a progestin that's actually contraceptive.
Okay. How did UCLA program delivery?
Yeah, so one of our arms there is cancer survivorship. And so we work really closely with, now this is gynec cancership, but then we also have breast cancer very directly linked with us. And so we see a lot of patients. We still have to work on, look, these are the arms we have. There's so many more arms I want to build. Like I want to build, we just built the derm arm. I want to build the rheum arm and cancer survivorship. There's so many cancers that we need to address. It's not just about the breast and the gynecologic cancers. So there's so much work to be done, but this was just the start, to kind of see if this kind of model would work. But yeah, cancer survivors they are the ones who actually have the worst symptoms. And so they deserve even better care. And we work alongside those departments as well. Yeah. 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 No, yeah, I couldn't go into everything here, but I will tell you that high-risk patients, first of all, that whole other option of toolbox of options, super important. But in terms of hormone therapy, every breast cancer patient is totally different. And so it's not a one size, hell no. No, it's not like that, right? So there's all sorts of types of breast cancer. So a person who's not estrogen receptor positive, very different patient population, a very different risk, I should say. And there is some argument to be made that they can be on hormone therapy. Right now, the guidelines say no hormone therapy for any breast cancer, but that's going to, I know that's going to change. And I know a lot of oncologists are much more open to this. And even DCIS is very different, right? That's ER/PR positive and treated, very different from someone who's not DCIS, and then also mastectomy, whether they've had a mastectomy or not. There's so much nuance to this. And so I again, never will say that I have given hormone therapy to breast cancer patients, but it's alongside the oncologist and also alongside the patient. And everybody's risk tolerances are different, right? There are people that are totally eligible for hormone therapy, but they don't want it. That 1 in 1,000 risk, it's not acceptable to them. And that's okay. We have other options, right? So that's why I bring it up in that sense, is that every person deserves to understand the risk. And ultimately, my job is to support them with knowing that risk in their decision. So most of my interaction is within UCLA, but it's not just one. Those were the lead physicians. But like, for example, for sleep, there was one person listed there, but there's 20 of them. It's just that they're the main one I work with, but that means like they help me build the algorithms. and they're the ones who helped educate everybody under them. So the same thing for oncology, the breast oncology team. So it's not just one person, but yes, do I specifically go out and talk to the community, other specialists? I'm going to be honest. I'm one person. I don't get paid for that to go out and speak. I mean, it's really hard to do with your own limited amount of time. I want to, but I think part of it is like these specialists have actually realized how important this is, and I think they're championing these efforts, right? And so that's what I want, is to instill that desire to go out and champion this in your spaces, and that's what I hope. Yeah.
We have time for one more question. And I think you have to answer first.
Thank you so much for the wonderful presentation. I just want to add a point of information looking at this menopause and all the symptoms from primary provider perspective, is that there's a lot of things cause fatigue and all of those lists. So make sure before you're saying, oh yes, it's menopause, that you're thinking of workup that other things are excluded.
Absolutely, absolutely, especially in the perimenopause time frame, or the early, and even like the younger women. You really want to make sure that thyroid's normal. You want to make sure. The one thing is that there's not really a role of checking estrogen and progesterone levels to diagnose menopause or perimenopause. It's really about symptoms and ruling out the other things, and then managing the actual symptoms. There's very few times where we actually have to check levels to figure out what's going on with them.
Well, that's everyone. So this concludes our lecture series for the spring. We will be following up with lots of information about the Women's Brain Health Initiative, the UCLA affiliates, and ways that you can stay connected to the university. Just want to thank you all for joining us this evening, and have a wonderful evening.